being a nurse. I developed the Charcot foot. With Charcot foot, the bones move around in the foot, and one of the bones dropped down and make a wound in the bottom of my foot. In the proximity where it is, it was difficult to heal. For 2 years, I was chair bedridden. I was allowed only to go out to the doctors. It affected me big time because I have all these little grandkids that I wanted to get out in the yard with and play on the swings and stuff with them, and I couldn't do any of that. I could sit in the chair and watch them. That was it. My husband, he became the nurse, and he really is an engineer. He was wonderful. He did so many things for me that I couldn't do for myself.
She couldn't do really much of anything except sit in that chair or lay in the bed, and it was taking a toll on her. Things I had to do with Dale before she had surgery was bring her food to her, help her get dressed, help her do everything, basically.
At one point, I said to Dr. Indu, "I've had enough. I want you to cut the foot off." And he looked at me surprised, but also said, "You're going to get through this, Dale. We're going to help you."
My name is Anthony Indu, but most people call me Bobby. I am an attending orthopedic surgeon in the division of foot and ankle reconstruction. So for traditional foot and ankle surgery, you end up doing large incisions, and those large incisions mean that you're doing a considerable large dissection for this patient, which means moving a lot of tissue aside to get to your goal. And when you have to do that, that means that there's going to be a considerable amount of more discomfort, scarring, as well as slower healing for the patient. What minimally invasive surgery allows us to do is remove a lot of those other ancillary portions of it and focus on the primary procedure. So that means less dissection, often less pain, and often a faster recovery for the patients.
My name is Ndu and Boakye, and I'm an assistant professor at Penn. I'm also the director of clinical research for the Foot and Ankle Division. When we think about the kind of general differences, a lot of the benefit is in the ability to get people kind of rehabbing more quickly. We usually have folks down or non-weight bearing for a shorter amount of time. The actual skin incisions, when they're that little, they take a lot less time to heal, and so you don't have to delay introduction of physical therapy based on your wait time for kind of incisional healing.
The conditions that we can use MIS for right now are a multitude. MIS was originally introduced regarding forefoot things like bunions and hammer toes, but there are some folks like myself and a few others around the country that are pushing that envelope and doing a lot more with it. So now we're doing things such as midfoot and hindfoot reconstructions, flat foot reconstructions, fusions, all sorts of different reconstructive procedures that are now opening up as we're exploring the envelope of what's available to us with minimally invasive surgery. So when you ask that question of, what procedures are there, quite a lot and growing.
When we think about who's a good candidate for MIS surgery, the answer is really most people, provided there isn't obviating reason like a big deformity that would really make MIS unsafe. But in the average person, I think it's really about buy-in and whether they have heard about it, whether they've had any sort of exposure to it.
So a few years ago, I had a problem with my left Achilles, and Dr. Ndu casted it for me, and that ended up working out fine. Then I started with pain in my right heel, and he took some x-rays, we did an MRI, and he says, "I really think you need surgery." The pain was to the point where I couldn't do my wound rounds, and I am a wound care nurse, and I would have to come home and ice and heat on my heel every night.
I have had bunions for the past 15 years. They were becoming more and more problematic until I got together with Dr. Indu. I had a little pain in walking and running and skiing. I also wanted to be able to spend more time with my dog and to do the kinds of things that I really like to do outdoors. I came here to talk to Dr. Indu. His warmth of manner and the caring way that he deals with patients won me over immediately.
One of the axioms that we push into our residents as they come through in training is that we actually don't save lives. What we do is save lifestyles. And by saving lifestyles, we restore people to function, which is what brings the joy back to life.
Now I can get up and I can get things for myself, and being more independent is just a godsend. Oh, they love it too. The youngest two, the 5 and the 3-year-old, I babysit them a lot. And I'm glad to be doing that again.
When you're in pain, you just can't really think about a lot of other things. You're just so focused on the pain and getting rid of it. So finally I gave in and we set a date, and the rest is history. And now I have absolutely no issues. I can feel my heel again. I can walk just fine. I have no pain, and it's all good.
My recovery was very quick. I was on my feet again within a week, but the recovery was remarkably simple to me. I couldn't believe how quickly things got back to normal.
My job is to really get people back doing the things that they want to be doing and contributing to the world, being functional and active in the ways that are meaningful to them. So if surgery can be less of a sort of insult to that, where they can really get back to life more quickly, I think it's a great way to kind of minimize the insult or the burden of surgery.
Talk to Dr. Indu. He will reassure you. He clearly knows what he's doing. He's got a lot of empathy for his patients. He wants to get them back on their feet and back doing what they love to do.
Penn medicine is innovative. I've seen it twice now with different conditions that I've had. They're very reliable. They're always available.
Dr. Indu, he is the most phenomenal doctor I've ever run across. And that constant reassurance made the difference.